Uterine manipulator is very important. For doing laparoscopic hysterectomy, understanding your uterine manipulator is of utmost importance. Do you know why? 50% of the work in the laparoscopic hysterectomy is done by the assistant who is holding the uterine manipulator. So, if uterine manipulator is wrongly held, wrongly manipulated, it will make your life hell. And you need to train your assistant in very nice manner. And there are many type of uterine manipulators. So, I am going to demonstrate you all the uterine manipulator. In the India, one of the most popular uterine manipulator is called, this is Mangeshkar uterine manipulator. Mangeshkar. And Mangeshkar uterine manipulator, this is called tip. And this tip is different sizes of the tip is available. Like 4 centimeter, 6 centimeter, 8 centimeter, 10 centimeter. You can open it from here. I am opening. And it is opened. And you have so many sizes. This size, this size, this size. And whenever you use the size, you should use 2 centimeter smaller than the cavity size. If you will use bigger one, you will perforate. You have seen that day. And it must be a smaller. So when you are putting a sound, you should measure. And remember, if you have perforated it, don't take it out. And don't reintroduce, remain perforated. Because if you will take it out and reintroduce, it will more bleeding. So once it is perforated, don't change. After that, don't change. Let it be there. Because if it is perforated, it doesn't harm. Am I right? But if you take it out and then take the smaller one, it will bleed. So always use 2 centimeter smaller than the cavity size. This tip. Why? Because cranial traction which we are giving is not given by uterine manipulator. It is given by Culpotomizer. We are pushing vagina, we are not pushing the uterus. Of course, together with the vagina, uterus get pushed. But you should never push the uterus. This rod should not be pushed. This handle has to push. So this is important, that this tip should be properly selected. After that, second part of this uterine manipulator is this tenaculum here. And ideally, tenaculum can articulating one. See, it is articulating. And it is bending here. And then this is opening the jaw, closing the jaw. So we can see here, this is articulated, and this is open the jaw, close the jaw. Open the jaw, close the jaw. Open the jaw, close the jaw. How it is done? By this handle. When I do like that, jaw is opening. When I do clockwise, jaw is closed. Anti-clockwise and clockwise, you have to rotate. So, and this is articulated. How you will make it straight? By this knob. See, when I am rotating here, it is becoming straight. And this is straight. And when I do like that, clockwise, it articulate. So this is important. And this is anti-clockwise, it is straight. After that, you have, so here there are 2 knobs. This knob is to open and close the tenaculum, the upper one. And lower one is to articulate. This one is to articulate and this one to open and close. So see here, this is opening and closing. Now after that, you have the Culpotomizer. And you have a different sizes of the Culpotomizer. Like you have 4 centimeter, 3.5 centimeter, 2.5 centimeter. These are the Culpotomizer. And you have to use the correct size of the Culpotomizer. Like suppose this is the uterus. This is the uterus. And if I will use this Culpotomizer, it will make my surgery worse, and I can perforate the bladder, because it is not going to push the vagina. What is the meaning of colpotomizer? Colpo means vagina. So it should push the vagina, but it will push what? Cervix. So if it will push the cervix, vagina, bladder and cervix become parallel over each other. It will not do tenting of vagina. It will do tenting of cervix. So it becomes cervicotomizer, not colpotomizer. So this is bad. This is good, because entire cervix has entered into this. So now what is pushing? Vagina, and bladder will be here, and it will tent the vagina. And once it will tent the vagina, over that you can push the bladder. So it will give you a platform to rub the bladder, and pearly white color vaginal fascia with the crisscross pattern of the vessel will be visible. And this pearly white color happens because of tenting of this colpotomizer. And always fat belongs to organ. So fat belongs to bladder, fat belongs to rectum, fat belongs to kidney, fat belongs to gallbladder, fat belongs to adrenal gland, fat belongs to a spleen, fat belongs to a stomach. So fat belongs to bladder. And when you push, and vein is behind the fat. So if you will push and keep the fat towards the bladder, there is no chance bleeding will happen. Unless until there is a severe cesarean section, multiple cesarean section, and bladder was sutured with the vagina, then during separation little bleeding can happen, but otherwise not. But that also the rule is that you should make a lateral window, and we feel this pearly white color, and by the opening the grasper, have you seen that day? We were spreading the muscle and then cutting the muscle near the uterus. Again spreading, making a lateral window and cutting it. So correct colpotomizer is very important, and entire cervix should enter inside the colpotomizer. Now, if you will use the very big one, then also it is not good. Like suppose this is cervix, that much thin, and this is colpotomizer, then it is bad. Do you know why? Because it will take you lateral, and you will cut the vaginal part of uterosacral. You will go more lateral, there will be vaginal shortening, and you may reach up to ureter. So loose also is not good, tight also is not good, there should be optimum. So it is important that assistant should select the correct size, and for that there are few cervical sizer which you can hold, and it will give you the measurement. I will show you that how cervical sizer looks like. So what is this? Colpotomizer. After that you have a vaginal seal. This is vaginal seal. You have 2-3 type of vaginal seal, and by default both is attached, but you have to, yes, so both will be there together, like, and you have to remove one of them. One of them you have to remove, and remember this part should be this way, like that, and by the company both comes together, but one you have to remove, and then you will tight the colpotomizer very tight. Done. After that you will keep it. Another you will attach the tip, that also should be completely tight. After that you will introduce the colpotomizer, and then you will introduce this into the cervix. You have to dilate the cervix up to 5 number of Hager dilator. And if the patient is nulliparous, 2 hours before the surgery, put 400 microgram mesoprost. right? Just like how you do for hysteroscopy, same way. Nulliparous only, if it or cesarean only. In cases of multipara, not required. After that, you will open it, and here we can see it is open the tenaculum, and then you go and catch the bite it over the cervix, like, and tight, and after that you will push it, and during pushing be careful that tenaculum should not get detached, and entire cervix will enter into the this. Done. After that, in the beginning this should never be pushed inside. In the beginning, if you will push it, it will obstruct your movement. And this is the way you should hold. Fulcrum. This is not to hold. This is, what is the purpose of this? Just to do anteversion, retroversion. And this is 5 o'clock, 6 o'clock, 7 o'clock, 11 o'clock, 12 o'clock, 1 o'clock. This is your 1 o'clock, not assistant 1 o'clock. Because your clock and the assistant clock is mirrored, reverse. Your this is 9 o'clock is assistant 3 o'clock, and your 3 o'clock is assistant 9 o'clock. Your 5 o'clock is assistant 7 o'clock. Am I right? Because I am here. So we are facing each other. You are surgeon, I am suppose assistant. So this is your 5 o'clock, my 7. So always surgeon's clock is respected, and you have to train your colpotomizer person, and he will give cranial traction not by this handle, and he will keep 12 o'clock, 6 o'clock, 5 o'clock, 7 o'clock, 3 o'clock, 9 o'clock, and just before colpotomy this has to be pushed in the vagina so that gas will not leak. Not in the beginning, otherwise it will do. So this is regarding the Mangeshkar uterine manipulator. Now another uterine manipulator which is very popular is called Clement Farand uterine manipulator. So now I will another uterine manipulator I am going to demonstrate you. This is called Marva uterine manipulator. In this Marva one, they also has a different size of the colpotomizer. You can see these are the different size of colpotomizer. But in this one you have a privilege that you don't need to have, and there is a screw there. This screw you will release, then it can go up or it can go down like that. And in this one you don't have to worry about the different size of the tip. First you will calculate that which size of the colpotomizer will be good. So like this colpotomizer is good, this is loose, and this is too much tight. So you will use correct size. Most of the Indian ladies 3.5 centimeter colpotomizer fit. 3.5 means if you will perform 100 hysterectomy, in that at least 80 hysterectomy 3.5 centimeter fits. So, and do you know most of the Indian lady 3.5 liter gas is required to create pneumoperitoneum. This we have seen in our practice. 3.5 liter लेती है Indian ladies, most 5.4 feet of the height, and even multiparous 3.5 liter में full हो जाता है, and then 3.5 centimeter of the size of the cervix. So now here what you will do, you will introduce the colpotomizer first, like this colpotomizer I am putting it, and after that you will push it here, and then this screw will be pushed up, and then automatically it enters into this, and as soon as it enters, now you tight it, and now it won't come up, and then you can do anteversion, retroversion, contralateral traction. It is very simple, but it has one problem. Problem is it doesn't have vaginal seal. So you need to have a gloves and push in the gloves and do. Another problem is it doesn't have tenaculum. So what happens? Sometimes uterus rotate. It rotates like that. When you are lifting it, rotates like that. Especially if you have some fibroid, it rotates. So this is less popular, that is called Marva uterine manipulator. Another uterine manipulator which is very popular is called, उसका colpotomizer वो दे दो उसका mix किया हुआ. Another very popular is called this Clement Farand uterine manipulator. This Clement Farand uterine manipulator, Clement Farand is one of the university in the France, and they have invented this uterine manipulator. So what is the advantage of? Almost everything is same like Mangeshkar, but it has one knob here. And once you will push this knob inside, then it can do further anteversion. You can see here. This is further anteversion and retroversion. So advantage is that even if your patient buttock is not up to the edge of the table, and if it hits like that, then you just press it and rotate it, and then it will go further anteversion, and then it get locked here. You can see it is locked, and once it is locked, I can do contralateral traction just by putting the finger. I can do contralateral traction, and this will be held like that. Here also two sides of the vaginal seal is given, and here also similarly different sides. Basically, Mangeshkar is a modification of the Clement Farand. Originally, CF uterine manipulator was there, and Mangeshkar is a Indian modification of Clement Farand uterine manipulator. And here also you have a different size of the tip, and you can open it from here. And here the good thing about, they don't have a tenaculum, but in their tip there is a screw there. So this screw you can tighten it. So it fixes just like how you are fixing the this HSG cannula. HSG cannula, same way. So initially how you will keep it? Initially you will keep it straight. इसको straight रखेंगे, and after that you will screw it like that. Am I right? And once it will screw in the cervix, after that you will push it. And once it is pushed, now you can do the further anteversion. And this way you can rotate it and you can pull it up. Or together you can do. So this is how this Clement Farand uterine manipulator. In Clement Farand uterine manipulator, there are some half circle colpotomizer also. Like suppose any of the uterus is no more possible to, cervix has some cervical fibroid, or there is some lacerated cervix or very bulky cervix, then full circle will not do, then half circle colpotomizer also you can use, because half circle can fit even in the bad cervix also. But problem of half circle is that you have to keep on rotating together. When your assistant is doing colpotomy, then it should keep, assistant will keep on rotating. So this is Clement Farand uterine manipulator. After that you have a Roomi uterine manipulator. This is the Indian modification of Roomi uterine manipulator. Here also you can see you have a different size of the tip, and this tip you can use the 6 centimeter, 8 centimeter, 10 centimeter, 12 centimeter, these tips are there. And any tip you can attach, another one you can remove, and this one you can attach it like that. And this is very good. And here what is the advantage? That just when you will do clockwise, it will do anteversion, and anti-clockwise it will do retroversion. So this is anteversion, retroversion. And to contralateral, just you have to rotate it, it will do contralateral traction. So suppose it is in, and then here also you will screw. Initially it should be a straight and a screw, and then this is anteversion, this is retroversion, and this is contralateral traction. In the original Roomi, which I will show you, there is a balloon there that is called vaginal balloon. But here, because original Roomi is disposable, it is of single use, but Indian modification of Roomi is reusable. You can autoclave it also and you can use it. After that, another type of uterine manipulator which is used is, this is a simple rod uterine manipulator which you will put it inside, and this colpotomizer has inbuilt. This also you can use. Another type of uterine manipulator is forceps uterine manipulator, this one. Here you can see when I am closing, then it is opening. When I am opening, it is closing. So this is closed, this is open. and there is a knob here for cervix. So what you will do, you will dilate it and then introduce it in, and then over this cervix will rest, and after that lock it. Now it will not come out, because after entering inside in the cavity it is open, so it cannot be taken out. And now anyone can do anteversion, retroversion, and even in the bigger cervix also it will be do similar job. So like it is a bulky uterus, no problem, it will go inside. So this is how you will put it like that and then lock it, and now it will not come out. It is not possible. And then anteversion, retroversion you can do, contralateral traction you can do. Here also only drawback is that you don't have Culpotomizer and you don't have this. So this is only good up to LAVH. This is not good for TLH. LAVH because we don't do colpotomy from above, we do from below by circumcision and then we push it. So this is good. So these all type of uterine manipulator you should know. And if you don't want to use uterine manipulator, then you will use Myoma screw. And Myoma screw you have two sizes of 5 mm and 10 mm. Where to screw the Myoma? At the place where two round ligaments join together. In the myomectomy, we repeatedly remove Myoma screw, reattach, remove, reattach. We want that we should go on the base. But if you are using with the Myoma screw in the hysterectomy, then this is a 5 mm Myoma screw and this is the 10 mm Myoma screw. So you should apply Myoma screw only one time, because if you remove and again apply, bleeding has started. And at this point on the anterior wall of the uterus, and where should be the port of Myoma screw? In between the pubic symphysis and umbilicus. And this is the anterior wall and you will screw like that. And then assistant who is standing in between the leg, what he will do? He will pull it towards him. And once he will pull it towards him, there will be cranial traction. And then contralateral traction, which I will show you in the lecture. I will show you how to do with the Myoma screw. So this is very important, because proper anteversion, retroversion and contralateral traction is essential when you are using any hysterectomy. So I am going to demonstrate you. This is the patient position. Patient buttocks must be up to the edge of the table, and you have to know the topographic anatomy. So I am just going to show you the Myoma screw as we have discussed. This is the one Myoma screw, that is the Mangeshkar Myoma screw. So Mangeshkar uterine manipulator, and this is the, as we have discussed, this is the different size of the tip. That is 6 centimeter, 8 centimeter, 10 centimeter, 2 centimeter smaller you have to select. What is this? Tenaculum. What is this? Culpotomizer, 4 centimeter, 3.5 centimeter, 3 centimeter, and one more is there, 2.5 centimeter. This is vaginal seal. This is what? Handle. That is also called fulcrum. And there is a 2 knob to rotate it. So this is simple. And this is Clement Farand. Clement Farand is one of the university in the France where they have invented. Here this is tip is also, you can do anteversion just by pressing here. This is angle given, 30 degree, 50 degree, 60 degree, and this 90 degree you can give complete 90 degree angle. And then it lock at any angle, this is 30 degree, 60 degree, 90 degree, it will lock. And once it lock, it remain that much anteverted. It has half circle as well as full circle Culpotomizer. And this is the best uterine manipulator of the world, that is called Roomi uterine manipulator. Roomi uterine manipulator is used in America and Europe, and in developed country where money is not a problem, it is used. This has a 2 balloon. This balloon is uterine balloon, and this balloon is vaginal balloon. This has a capacity of 10 ml, and this has a capacity of 50 ml saline. 50 ml you can put, and then you can, what is the advantage? This circular ring, little bit gas will leak. You cannot prevent the entire gas leak. Why? Because even if it is inside, these are from this place, gas will leak, isn't it? Because even if it is there, see, it is loose, so gas will leak, and this also cannot take entire shape of the vagina, because vagina is not completely circular, it is anteroposterior less, laterally more, isn't it? So little leak is there that you cannot stop, and your insufflator will take care of that, because if leak is 2 or 3 or 4 or 5 liter per minute, insufflator will start flowing at that rate. But here it is a balloon, so it take a shape of the vagina. Another, it doesn't have tenaculum, so purpose of this tip is that uterus will be inside like that, cervix will enter into this, so it doesn't come out also, and there is no chance of any perforation because this tip is soft, just like a Foley's catheter, so you cannot perforate and it will not rotate also. Initially, in the beginning, this balloon should not be inflated, it should be inflated only at the time of colpotomy. So this is the Roomi uterine manipulator, and they also have a, this is called Koh cup or Koh colpotomizer, and they have also different length of different diameter of the colpotomizer. And here also you can see this is 2 centimeter smaller than the cavity size, and this is a uterine balloon which take 10 ml, and this is vaginal balloon which take 50 ml. And this handle which you are saying, if you will rotate clockwise, it will do anteversion, and when you rotate anti-clockwise, it do retroversion, and for contralateral traction, right and left will be rotated. So it's very good, and they give you one cervical sizer, and you know advantage of this cervical sizer is that at this place it will give you numbers like this number 2.5, 3, 3.5, and you can decide that which size of colpotomizer will be possible, because once you hold it, this number will come and you don't have to do hit and trial. You can easily recognize, so that it should not be loose and it should not be tight. So this is called cervical sizer, and this you can use. So we will see the video, one video of how to use this Roomi uterine manipulator. This is from Cooper Surgical, which is one American company which is making this uterine manipulator. And you will buy, they will give you different size of this silicone tip, like 4 centimeter, 6 centimeter, 8 centimeter, 10 centimeter, 12 centimeter. These are the different size of the silicone tip is coming. After that, you will attach it like that. And these are the different sizes of the Koh cup, that is 2.5, 3.5, then 4 centimeter. Mostly this 3.5 is used. And now you will dilate the cervix, attach the colpotomizer, and you will push it into the cervix, and this enter into the uterine cavity. Once it enter, then this is 10 ml syringe. Outside you have a 2 tubes are there to attach in the syringe, and you will attach it, and 10 ml saline you will fill up. Now it won't come out, just like Foley's catheter. Now it cannot come out, and after that you will push the colpotomizer, and appropriate size of the entire cervix is inside. And then there is a lock in the colpotomizer, so you will fix this lock, and once this lock is fixed, now this colpotomizer also won't come out, it will pushed in. And after that, anteversion, when you will rotate clockwise, this is clockwise, it do anteversion. When you rotate your hand, and here even if the buttock of the patient is not up to the edge of the table, there is no problem, because it is not working on lever action. Because in the Mangeshkar or in the Clement Farand, outside once you put down, inside it go up, outside right, then inside left. But here it is not required, just you have to rotate it, and when you rotate clockwise, it go anteversion, and when you rotate anti-clockwise, this is anti-clockwise, it go retroversion. And in the beginning, when you take upper pedicle, then this balloon is empty. It should not be distended. And anteversion, retroversion you can do. Once the round ligament, fallopian tube, ovarian ligament, 2.5 centimeter of the broad ligament is done, and now you are reaching to uterine and colpotomy, then you will distend this balloon, and 50 cc saline here you will inject. And now purpose is that gas will not leak, and then you will do colpotomy. And colpotomy you will do over the tip of colpotomizer, and then uterus come out. This is cervical sizer. So you can see once you will hold the cervix here, this is the cervix, then here numbers comes, and we can see this number is 2.53, 3.54. So if it is 3.5, that means 3.5 centimeter of colpotomizer will be required. So this is called cervical sizer. And if you don't have, then you have to do hit and trial. You have to put a sound also, and then you have to select the appropriate size of the silicone tip, 2 centimeter shorter, 2 centimeter shorter, not of the same size which is tip. And you have a different sizes from 12 centimeter up to 3.7 centimeter, depending upon, suppose you say postmenopausal patient, you will use very small atrophic type of uterus. So this is full range of flexible silicone tip is available, and this is how you will put it. And this is the your silicone tip, and it has 2 balloon, one for, and outside you have a 2 tubing to attach. So this is the 10 ml saline, and you will inject, this balloon is injected, and later you will another one, you will push the colpotomizer and fix it. You should train your nurse how to do that, otherwise you have to do yourself. Using the uterine manipulator and correctly using is very important, because uterine manipulator person do 50% of the task they perform. So this is pushed inside. You should apply some xylocaine before pushing in the vagina so that it slide better. It should not traumatize, otherwise tear and it can injure the skin of the vagina. And then there is a lock here. This lock you will press, and then this colpotomizer won't come out. There is a black part of this here which will show you that it is reached up to the tip here. You can see there is a black line, and this line will show you that it has reached up to the tip of the vagina, means entire cervix is inside. It will let you know, and here, and then you will lock once it reach at this point. So this is scientifically designed, very good quality of uterine manipulator, but only drawback is that single use. And the problem is that Roomi system is less used in Asia because of cost. And this is another video to show you the same uterine manipulator. These are different size of the colpotomizer, and how to use. Basically you should do yourself, or your assistant should be intelligent. This is the tenaculum which is holding the cervix. Now you will put a sound and you will check, and then dilate the cervix up to 5 number of Hager dilator. So this is cervical dilatation, and once it is dilated, after that it is ready. If you cannot dilate it, it will be difficult, and you can only use cup part of the colpotomizer. Tip you have to remove. Now this is the silicone tip, and it has a 10 ml, and this is 50 ml balloon. After that you will put one seal over that, so that any direct coupling should not happen. This seal, this is a polythene seal which has advantage, this metal part will be hidden. So suppose you are using hook or a spatula, then it will not touch this metal part, otherwise vagina will burn. So this is important, and this part is plastic, so it cannot take current. And then cervical sizer has measured the size of cervix. After that you will push this colpotomizer and tight the colpotomizer according to size of the cervix. So now it is ready. If you will rotate clockwise, it is anteverted, and when you rotate anti-clockwise, it will be retroverted. Initially, during introduction, it should be straight. It should not be either anteverted or a retroverted. It should be straight, and then you will put it in. And the cervix should completely enter, and this tip of the colpotomizer only touch the vagina. Only touch the vagina. If you have a bulky cervix, then you have a extra large colpotomizer or half circle colpotomizer you can use. So this is ready now for, and this is for contralateral traction. Right and left you will rotate for contralateral traction. So let us put it now, and sometime in very healthy and soft cervix you may take a bite over the cervix. Otherwise tenaculum itself will do the job. And here we can see this speculum is removed, because with the speculum colpotomizer won't be possible to push. Here just you can use a straight retractor, or you can use seams a small size, and then this cervix will be put inside the colpotomizer. Entire cervix should enter into the colpotomizer. And it is in. Just to see better, you can use one retractor, right angle retractor, and we should make it sure that entire cervix is inside the colpotomizer and tip of the colpotomizer is touching the vagina. And it should be tight, not loose. And it is done. We can see here this colpotomizer is also of 3.5 centimeter. It is written here 3.5 centimeter. So mostly average, this is the maximum number of used. And now it is done. And now you will start the surgery by an outside anteversion and retroversion should be performed. So this way, this is CF uterine manipulator, that is Clement Farand uterine manipulator. That is one of the company of the France. So you will see how to use this CF. Here also similarly you will put a speculum and carefully you will dilate. So this part I am just escaping because already you know how to do that. And now here we can see this is how buttocks must be edge of the table, and for that you must use a shoulder support. If shoulder support is not there, then the patient is slipping towards the head. So this is one small device, but people are generally forgetting it. So this is shoulder. Like today also in the OT you have seen that in beginning it was not there. Shoulder support of OT table. And this has advantage that your assistant can give proper cranial traction. If it is not attached, patient will slip. So this is shoulder support. See here how it is supported. So this every OT table has this. This is shoulder support, and patient will not slip towards the anesthetist. And then you can give more cranial traction. More cranial traction is more safer, because your bladder will remain down, rectum will remain away. Uterus should come in the abdominal cavity, it should not be in the pelvis during the surgery. So this shoulder support is important, and buttock should be up to the edge of the table here. This is, we can see buttock is up to edge, and outside when you will put it down, inside it move up, and outside you will move right, inside it move left, because it is a lever. Just like in laparoscopic instrument, when outside we are moving up, inside it is going down. So same way. And then this fulcrum will be to rotate. If your cervix is little bit bulky, you can use half circle, and this is how you can further do the anteversion, as we have demonstrated you that this is further you can do anteversion and retroversion by pressing with this thumb. You have to press this knob down, and then it can, as soon as you will remove the thumb, it get locked at that position, and then it is very convenient. And now if you are using half circle colpotomizer, you have to rotate this handle so that we can see once outside it is 12 o'clock, inside this colpotomizer is 6 o'clock. But normally half circle should not be used, because half circle has a problem that it go away from the cervix. Just like if you will, this is full circle collar, and in full circle collar will be always around the neck. But if it is half circle, suppose you will open all the button, then it will fly away from the neck. So problem of this half circle is that when you are doing anteversion, it has a tendency to go away. And if you will depend upon this tip of the colpotomizer, you can injure the ureter. You got it? Or you can do shortening of vagina. Because what is this? Uterosacral. And in full circle, colpotomizer will be here. In half circle, it is here. See the movement of colpotomizer. Are you seeing that? See. So you have to be very careful that if assistant put half circle colpotomizer, you should never use colpotomizer as a reference point to do colpotomy. You should decide your own colpotomizer point, because half circle should not be applied in every case.